Thank you, Chairpersons. So at the outset, I'd like to thank Dr. Manoj and Dr. Purvi for having had invited me. It's indeed a pleasure to be back here. I grew up in Mumbai. I've lived here for 30 years. Now I've settled down in Bangalore. So it's nice to always be here. So my topic is actually incretins and hypoglycemia. We all have been using incretins for many, many years now. It's almost 2 decades since the DPP-4 inhibitors have been launched in the country. And of course, now we have the GIP-GLPs, we have the GLP-1 receptor agonists. So all these drugs are something that we commonly use in our practice. Now, I'll try to highlight whether these drugs, either individually or in combination, pose a risk of hypoglycemia from some of the published data. Now, hypoglycemia, my previous speakers have already alluded to, that you have three levels: below 70, below 54, and below 30 you go into the stage 3, which is neuroglycopenia, where you require third party assistance, and that can be detrimental. It can lead to the death in bed syndrome as well. Now, what are the drugs that generally predispose to hypoglycemia? So generally insulins are very notorious. You all know that basal bolus insulins, premix insulin, especially the older ones, human insulins carry a higher risk or higher propensity for hypoglycemia. Incretins, they do have a minimal risk if given individually or as a monotherapy, but if you combine them with a sulfonylurea or with an insulin, then we know that the risk automatically increases. Now, everybody here understands the incretin effect, right? So an oral carbohydrate intake produces a much higher insulin secretion as compared to an IV administration of glucose. This was the one that was first demonstrated, and researchers could understand that we have certain cells or certain hormones in the gut that are responsible for this effect. And thus came the discovery of DPP-4 inhibitors and then GLP-1 receptor agonists. Now, talking about GLP-1 receptor agonists, what is their mechanism of action in trying to reduce the blood sugars? Now, we know that GLP-1, they have a glucose-dependent insulin secretion. That how much the blood sugar is rising, only that much insulin will be secreted. Now, these are all the receptors, the GLP-1 receptors, which you find on the alpha, beta, and also the delta cells. We know that delta cells, they release somatostatin, which depending on the blood sugars might stimulate an insulin secretion or might stimulate a glucagon secretion. So GLP-1s, mainly they act through the PI3K AKT pathway. This is the main pathway that is responsible for this glucose-dependent insulin secretion. So what do they do by this? They try to reduce the fatty acid oxidation, they reduce the hepatic gluconeogenesis, and they improve the energy expenditure in the peripheral tissues. Also, they have another function within the beta cells. They can try to reduce the apoptosis. That is one of the reasons why, if you see in most of the studies, incretin drugs like GLP-1s, they can preserve the beta cell function and the beta cell mass. Now, on the delta cells, they bind and they will again try to stimulate more of an insulin release, and somatostatin in turn will try to inhibit the alpha cell release of glucagon. Now, GLP-1 action on glucagon is only in the hyperglycemic state. It's not in the hypoglycemic. In the hyperglycemic state, it will blunt the alpha cell release of glucagon, and on the other hand, the beta cell stimulation of insulin release. In a nutshell, this is the main action through which GLP-1s bind to the receptors on the alpha, beta, and the delta cells to regulate the blood sugar. What about GIP? GIP, on the other hand, has got a dual action. So we know that when there is hyperglycemia, it will act on the beta cells to stimulate glucose-dependent insulin secretion. But when the blood sugars are going into the euglycemic or maybe the hypoglycemic state, then automatically it will try to stimulate, it will bind to the receptors on the alpha cells and stimulate the release of glucagon. So it's like a switch action it has. Hypoglycemia, insulin action. Hypoglycemia, you have the alpha cell glucagon release. So this is the main action of GIP. So GLP-1 basically does not have any action during hypoglycemia. It is purely dependent on the counter-regulatory hormonal response. If a patient has autonomic neuropathy or if the other counter-regulatory hormones are lesser, then the patient on a GLP-1 receptor agonist might still, experience hypoglycemia. So it does not have an action on the in hypoglycemia to try to raise the blood sugar. Now I'll come to some of the clinical studies. Now this is evidence from a meta-analysis. And here what is seen is that alpha glucosidase inhibitors, SGLT2s, thiazolidinediones, DPP4 inhibitors have the lowest risk of hypoglycemia. The highest risk is seen with sulfonylureas. The odds ratio can be as high as 6.5. Also meglitinides, slightly lesser than sulfonylurea, but still the risk is high, around 6.3. So there is something called the SUCRA rating, which rates the level or the intensity of hypoglycemia, and it is seen that DPP4s and thiazolidinediones carry the lowest risk of hypoglycemia. Now talking about DPP4 inhibitors, some of the CVOT trials that have been completed, and if you see in all these trials, whether it is sitagliptin, Saxa, Lina, Allo, or even vildagliptin does not have a dedicated CVOT trial, but from whatever RCTs and the VIVID trial, it is seen that hypoglycemia as a monotherapy is very, very minimal. And you know that in the Savartimi, there's an increased rate of hospitalization, but that was not due to hypoglycemia. It's mainly a heart failure outcome. Similarly, allogliptin, slightly increased rates of heart failure hospitalization, but not due to hypoglycemia. Now, sulfonylureas, if you combine it with DPP4 inhibitors, then that automatically increases the risk of hypoglycemia. So this again is a meta-analysis, and you can see that it's better to give a monotherapy which favors the placebo as opposed to a DPP4 with sulfonylurea. So across the trials, when you combine it with sulfonylurea, the risk of hypoglycemia, the pooled risk ratio can be 1.66, confidence interval between 1.34 to 2.06. Now, other thing what they found out in this meta-analysis is that the hypoglycemia risk with the sulfonylurea DPP4 combination is dose dependent. If you give a lower dose of sulfonylurea, let's say glimepiride 0.5 or glycoside, let's say 30 milligram, then even in a combination, the risk is much lower as opposed to giving glimepiride at 4 or 8 milligram or glycoside even 120 milligram. So dose dependent risk when you combine a sulfonylurea with a DPP4. So they've concluded here that if you initiate with DPP4 as a monotherapy, the risk is much lesser, but if you combine with a sulfonylurea at a higher dose, then the risk can be much higher. Now looking at all the OHAs, which I've already mentioned, so sulfonylureas and insulin, you can see here, they carry the highest risk. So exogenous insulin administration and sulfonylurea at higher doses, whereas the lowest risk of hypoglycemia has been seen with the GLP-1 receptor agonist, SGLT2 inhibitors and DPP4 inhibitors. The relative risk is 1. Then followed by that thiazolidinediones, glenides, and then like I said, urea, insulin, highest risk. Now talking about another meta-analysis. This was with GLP-1 receptor agonists, and they wanted to compare with DPP4 inhibitors and with insulin, what is the relative risk for hypoglycemia. Here again, you can see here in this forest plot graph that basically in all the trials, GLP-1s carry the lowest risk when you have to compare it with insulin. And similarly here, the 3.2 graph with DPP4 inhibitor, slightly higher than GLP-1, but again, much better than insulin. Talking a little bit about the perioperative use of incretins. I'll talk first on DPP4 inhibitors. So these are non-critically ill patients who have been hospitalized in the medical or surgical ward. And here there were two groups. So one is the basal bolus group, another is the DPP4 basal insulin. So is that better or comparable with basal bolus? If you see in this graph here, the blood sugar control was almost similar, but main benefit was hypoglycemia. So if you combine a DPP4 with basal insulin, then the hypoglycemic events are much lesser as compared to basal bolus regimen, whether in the general medicine wards or even in the surgical wards. Similarly, the lower graph here, the bottom hand graph, here again linagliptin with basal insulin versus basal bolus. for patients who have undergone a non-cardiac surgery. This again is data from an RCT. Here again, the glycemic control was similar between the groups, but hypoglycemic events and episodes were much lesser with Lena basal as compared to basal bolus regimen. And lastly, there's also real world data which says if you combine a DPP like Lena with basal, then the effectiveness is same, but hypoglycemic rates are much lesser as compared to basal bolus. Now CABG is something that many of our type 2 patients routinely undergo. So here again in CABG patients, if you use a sitagliptin, there are some instances of post-operative hyperglycemia. So sitagliptin could not prevent that. But what it did help was the insulin requirement during the perioperative period was much lower, and also the hypoglycemia was much lesser. So this can be one benefit. Patients have to be put with sitagliptin and a basal insulin during the perioperative period in CABG patients. Now talking about GLP-1s and perioperative, whether pre, intra or post-operative use, this again is a meta-analysis. So here again they've seen that glycemic control was definitely in favor of GLP-1s, but hypoglycemia was the main benefit. So if you see the odds ratio, it's only around 0.6. And also the requirement for rescue insulin administration was significantly lesser in these patients who took GLP-1. So thereby, this is the benefit you can get in perioperative patients. But these are some things, red flags that have been raised, which we have to be careful about. The risk is you can have GI symptoms. So there is, that delayed gastric emptying, so elevated gastric residual content. That's one of the high risk for odds ratio. But benefit is lower insulin requirement. There's a good blood sugar lowering, and mainly the benefit of hypoglycemia that can help most of the patient. But only thing is the patients can have nausea, vomiting because of a reduced gastric emptying. That's something we have to be careful about. Lastly, I'll talk about a recent meta-analysis. This was done in 2025. So here it was done in all adult type 2 diabetic patients, and they've compared the use of GLP-1s to placebo, and the patients have taken the drugs at least for a period of around 2 months, and they wanted to see the key outcome was hypoglycemia risk with all the GLP-1 receptor agonists. So almost 26,000 type 2 diabetic patients were studied here. And in this study, they concluded that semaglutide is one of the newer GLP-1, whether oral or injectable, had a higher risk for hypoglycemia, followed by exenatide. Relative risk is 4.6 and 3.3 as compared to all the other GLP-1 receptor agonists. So in this critical analysis, they have concluded that you need to be a little careful with sema and exenatide. Exenatide, any which ways, we don't use here for hypoglycemia. So again, deep diving into this meta-analysis. So they're saying that if you compare it with all the other traditional drugs, so liraglutide and lixisenatide, which is still there in our country, there the hypoglycemia risk is much lesser. Also with dulaglutide. So they're saying from this network meta-analysis that tirzepatide again had one of the lowest risks. The sema and exenatide BD had slightly higher risk. So you have to be careful about hypoglycemia here. Now looking at some of the guidelines. Now guidelines, have recommended if you want to use GLP-1 receptor agonists in obese people. So one is in obese people with type 2 diabetes. If they are already on insulin, if they're taking sulfonylureas, then you need to monitor them closely. The risk of hypoglycemia can be there. You might have to reduce the dose of sulfonylurea and insulin if you need to mitigate this risk. And if these obese patients with type 2 diabetes, they are in the perioperative period, then the aspiration risk because of GI side effects can be higher. There you might have to hold the GLP-1s or bridge it with other agents. Similarly, if you look at GLP-1 receptors in obese people without diabetes, so the risk generally for hypoglycemia is minimal. And if they're also undergoing a surgery, only the aspiration and GI side effect risk is there. So at those instances, you might have to hold the GLP-1. Looking at some of the other clinical trial data, GLP-1 receptor agonist and hypoglycemia. So here again, it is seen exenatide BID, which I already showed in the other meta-analysis. has a slightly higher risk, whereas sema and lira here has got a rare risk of hypoglycemia, and dulaglutide once week has got the lowest risk as a monotherapy for hypoglycemia. Now, lastly, I'll try to summarize with semaglutide and tirzepatide, the GIP/GLP. So, semaglutide in obese non-diabetic patients. Now, obesity treatment has really picked up in our country. I think everybody are using sema as well as tirzepatide. So, data from the STEP trial, STEP 1, 2, 3, 4, 5, as published in NEGM, and semaglutide used at its maximal dose, that is 2.4 milligram. The findings from a summary of all the STEP trials have clearly shown that hypoglycemia is rare but slightly higher than placebo, especially in people with pre-diabetes. So if they have impaired fasting glucose, then the risk of hypo can be slightly higher. And this mechanism we know, it's because of caloric reduction, early satiety, reduction of hunger, reducing the gastric emptying. So that can lead to a glycemic variability. And if you concomitantly administer a sulfonylurea or insulin, then the risk of hypoglycemia is higher. Perioperative settings, it has not been studied adequately, but impaired glucose tolerance, impaired fasting glucose, there the risk can be slightly higher. So they've concluded here from all the STEP trials that in obese non-diabetic patients, an unexpected hypoglycemia can be seen in some of the people taking the higher doses of sema. So once weekly 2.4 milligram. And you need to closely monitor especially elderly patients and patients with an impaired nutritional intake. Lastly, tirzepatide. So tirzepatide in obese non-diabetic patients, we know it's a twin cretin, and we have a lot of data from the SURMOUNT trials, the SURMOUNT 1 to 4. And here it is seen that, of course, we start with the lowest 2.5, we up titrate, and we can go up to maximum 15. Actually, the maximal doses that we can give is 5, 10, and 15. They are the maintenance doses. And like I said, the GIP of this twin cretin will try to mitigate the effect of hypoglycemia. So hypoglycemia with tirzepatide in SURMOUNT trials has been very, very low. So they're saying that you can use this drug in all obese people. With 15 milligram, the risk is slightly higher as compared to 10. You can see here, and then the 5 milligram for hypoglycemia. So these are my last two slides, the practical use and take home messages. We need to personalize medicine. We need to personalize the way that we treat our patients. Perioperative use of GLP-1s or DPP-4 inhibitors is not very clear, especially in the nil per oral period. Obesity is a new frontier, and we've started to use a lot of sema and tirzepatide, but still lot of data, especially for safety, is awaited. And we know that if you combine these drugs, incretins with sulfonylureas or insulins, then the risk of hypoglycemia is that much higher. Guidelines are evolving. ADA 2025 has already endorsed the use of GLP-1s in obesity, but risk stratification of hypoglycemia is still lacking. Technology will be central. Dr. Vinay has already mentioned time below range and how we need to closely monitor with whatever sensors are available. And a lot of real world data will be very essential in the future, especially for hypoglycemia. So we need to balance the risk benefit ratio. But as a monotherapy with a lower dose of sulfonylurea and insulin, we can definitely mitigate the risk of hypo and have a good benefit for the patient. Thank you for a patient here.